Good morning to all SSs and my fellow friends. This is my group names and our metric card numbers. So this is our presentation case today. It's all about chronic hypertension, pre-existing hypertension. This is our presentation outline. For the introduction, a chronic hypertension in pregnancy is defined as blood pressure more than 140 mmHg systolic and 90 mmHg diastolic occur before 20 weeks of pregnancy. And for PIH is the same as a chronic hypertension, but it's occur after 20 weeks of pregnancy. So how can we suspect patients having chronic hypertension or PIH? Usually during the booking, right, the first visit, we need to check the patient BP. And then when we take the first reading of BP and the BP more than 140 90 mmHg, we need to check for the second reading. The gap for the first reading and the second reading must at least 4 hours. And if the two readings, the BP reading is more than 140 mmHg, we can suspect this patient having hypertension, chronic hypertension or PIH. Usually, chronic hypertension affect 1% to 5% of pregnancy, whereas PIH occur in up to 5% to 10% for all pregnancy. This is our patient biodata. She is 42 years old. She is Malay from Indonesia. She live in Kampung Siantan, Serian with her husband and 5 children. She studied until primary school but in Indonesia. She got married in 1997. She is working as a waitress in one of the restaurant in Serian town, and her husband she is gardener, but she is Malaysian. She is G6 para 5A0. A physical examination was done on 22nd of September. Patient looks well and comfortable with no active complaint that time. The vital sign is normal, and head to toe examination is done. Head appearance is clean. No presence of dandruff and lice. Pink conjunctiva. No discharge from the ears and nose. No dental caries present. No present thyroid gland and lymph node enlargement. No lump presence on the breast and axilla. No discharge from the nipples, and breasts are suitable for breastfeeding. No tremors. Capillary refill less than 2 seconds. No edema at the lower limb, but presence of varicose vein at her right leg. The varicose vein appears during the pregnancy. Before the pregnancy, she doesn't have the varicose vein. Clean genitalia and no pervaginal bleeding. During the abdominal examinations, the size of the abdomen corresponding with the POG, round shape, skin clear with no rashes, no caesarean scar, but presence of linea nigra and stria gravidarum. During the fundal palpation, fundal height corresponding with the pregnancy gestation, which is 27 cm, presentation of fetus that time was oblique. Fetal heart rate was 140 mmHg, 140 bpm, and fetal movement felt open palpations. And for the history, my friends going to talk about it.
Next, I will talk about our client history. First is obstetric and gynecology history. Our client has a history of low birth weight baby, which is less than 2.5 kg for her last child. She also has a history of long spacing pregnancy, which is more than 5 years. Her last pregnancy is in 2008, while the current pregnancy is in 2020. Our client has no gynecology-related illnesses. And as for medical history, our client is diagnosed with hypertension in 2008, but she defaulted her treatment and follow-up since then. For surgical history, our client has no history of surgery including cesarean section surgery. As for her family history, her mother is diagnosed with hypertension and is currently on medication, whereas her father died due to old age. As for social history, our client lives with her husband and 5 children at home. She and her husband are the breadwinner of the family. She works as a waitress in a restaurant and earns about Rm 25 per day. She is a non-smoker and non-alcoholic. However, her husband is a smoker and smokes around 10 cigarettes per day. She has a history of taking family planning medication via injection Depo-Provera after her last pregnancy, but then she defaulted her family planning medication in 2017. Next, we will talk about the pathophysiology of pregnancy-induced hypertension. Pregnancy-induced hypertension happens due to abnormal cytotrophoblast invasion. This invasion will lead to reduced perfusion to the placenta. This reduced perfusion will cause the placenta to experience ischemia. Ischemic placenta will release cytokine factors that lead to endothelial dysfunction. This endothelial dysfunction will lead to decreased renal pressure natriuresis, that resulting in hypertension in pregnant mother. Next, the clinical manifestations of pregnancy-induced hypertension. The first one is the blood pressure will be more than 140 over 90 millimeter mercury, or there will be an increase about 20 millimeter mercury either in systolic or diastolic pressure. Next, the client will experience headache, dizziness, visual disturbances, and blurry visions. The client may also complain of having nausea, vomiting, epigastric pain, and the common one is pitting edema at the lower limb. If the client has progressed into preeclampsia, the urine albumin test will indicate proteinuria.
Laboratory investigation. The several laboratory tests undergone by Madam Y in the clinic are: first is the antenatal test during the first booking on 19 August 2020, which comprised of blood research, venereal disease research laboratory (VDRL), HIV and blood film malaria parasite test (BFMP). Blood research test was taken to ensure that the mother and the baby's blood is compatible to each other so that no complications during or after birth would occur. The result was B positive. Meanwhile, VDRL, HIV, and BFMP showed negative results. Second is the urine albumin and glucose test. The tests were taken from the mother's first booking, which is from 19 August 2020 to October 1st, 2020. The tests are done on every antenatal clinical visit. Both results showed negative findings. The urine albumin test is one of the indicators of preeclampsia, PE, and the result showed significant proteinuria of 2+. Meanwhile, urine glucose acts as an indicator of gestational diabetes mellitus, GDM. Third is hemoglobin test. This test is also taken on every antenatal clinical visit. The mother's baseline hemoglobin reading is not known due to late booking. Her first booking was on 19 August 2020, which was at 24 weeks of pregnancy. Her result was 11.6 gram per deciliter, which is normal. Therefore, at second trimester, the mother is not anemic. On subsequent visit during her third trimester at 28 week of gestation, her hemoglobin result was 11.7 gram per deciliter, which was also normal. There was also a slight increase in the hemoglobin level, which is normal for pregnancy in the third trimester. On the latest visit at her 30th weeks of gestation, her hemoglobin result was 12 gram per deciliter, which is also normal. It can be seen that her hemoglobin level keeps increasing throughout the pregnancy. This could indicate that the iron supplements taken are working well for the client. Fourth is MOGTT, Modified Oral Glucose Tolerance Test. It is done to screen for GDM. It is tested on every mother, aging 25 years old and above. The tests were taken on 25th August 2020 and 3rd September 2020. Both results showed normal findings, therefore Madam Y does not have GDM. Fifth is liver function test, LFT. It was taken on 21st August 2020 to test on the liver enzymes in order to screen for PE or preeclampsia, as well as HELP syndrome in pregnancy. HELLP stands for H hemolysis, E elevated, L liver enzyme, L low, and P platelet count. The result from this test was negative. Treatment plan and management. In terms of pharmacological treatment, the mother is currently prescribed with tablet aspirin 150 mg to be taken once daily, tablet calcium carbonate 1 gram twice daily, tablet ferrous fumarate 200 mg once daily, tablet folic acid 5 mg once daily, tablet vitamin C 100 mg once daily, and 1 tablet of vitamin B complex once daily. Aspirin is taken as a prophylaxis for preventing preeclampsia by lowering the blood pressure. This prophylaxis is given to pregnant mothers who are at moderate or high risk of hypertensive disorders. It should be taken at 12 to 36 weeks of pregnancy. Calcium carbonate is used together with aspirin as a prophylaxis for preventing preeclampsia. It should be taken from 20th weeks of pregnancy until delivery. Ferrous fumarate prevents anemia. Folic acid is taken to prevent neural tube defects such as spina bifida and anencephaly. Vitamin C is taken to increase iron absorption. Vitamin B complex is taken to lower the risk of birth defects and to promote the production of red blood cells. Non-pharmacological treatment. The mother was advised to avoid high-sodium foods to prevent blood pressure from rising. The mother was encouraged to elevate legs while resting or sleeping in order to prevent fluid retention and edema in lower limbs. Fetal kick charting was explained to the mother. It needs to be done every day in order to monitor fetal condition. Monitor the progress of blood pressure, fetal heart rate, and urine tests, which includes both albumin and glucose. So this is the mother's antenatal progress. Madam Y was ordered to do biweekly blood pressure with urine albumin and fetal heart monitoring. So far, the only blood pressure that can be considered as high was taken on 25th August 2020 during her 25th weeks of gestation. However, the mother's pulse rate was normal, which is 72 beats per minute, and she had no shortness of breath, no chest pain, no blurry vision or visual disturbances, no nausea, no epigastric pain, and no symptoms of impending eclampsia. Recommendation: explain to the mother the risk factors of chronic hypertension, such as first-time mothers, women whose sisters and mothers had PIH, women carrying multiples, women younger than the age 20 or older than age 40, and women who had high blood pressure or kidney disease prior to pregnancy. The mother is well informed that having a history of chronic hypertension will increase the risk of recurrent chronic hypertension in the next pregnancy. Explain to the mother about the warning signs and symptoms of chronic hypertension, such as sudden weight gain, nausea, vomiting, headache, pain in the upper right side of the belly, and visual changes, such as blurred or double vision. Advise the mother to always be alert with these signs and symptoms. Explain to the mother the complications of chronic hypertension to both fetus and the mother if it's not well controlled. The risks are increased risk of getting pulmonary edema due to fluid overload and oliguria, high risk of getting chronic hypertension after delivery, increased risk of getting placental abruption. This happens when the placenta gets separated from the uterus too early, that it then causes bleeding. Increased risk of getting seizures due to intracranial hemorrhage. This increases the risk of early labor through cesarean section as soon as possible. Increased risk of getting intrauterine growth restriction IUGR due to reduced placental blood flow. Next is follow-up. The mother should always attend antenatal follow-up as regularly as scheduled to monitor the mother and the fetus well-being. Attend ultrasound scan to monitor the fetus growth and well-being. Do weekly blood pressure monitoring and urine tests as ordered to monitor the progress of the chronic hypertension. In terms of nutrition, the mother needs to limit the intake of salt diet in order to prevent the increase of blood pressure, which may result in preeclampsia. Advise the patients to take enough protein, calcium, vitamin B, vitamin A, iron, and folic acid. Strict fetal kick charting. Advise the mother to strictly monitor fetal kick count using fetal kick chart. Advise the mother to visit to nearby clinic or hospital as immediately as possible if there is any diminished fetal movement, which is less than 10 counts within 12 hours period. Next, treatment. Advise the mother to take hypertensive medications at the right time with the right dose until delivery. Advise patient to not take any hypertensive medications without doctor's prescription. Resting. Advise the mother to rest well and sit while working. Advise the mother to elevate both legs to prevent edema. In terms of family planning, advise the mother to not stop taking family planning medication before getting consultation from doctors. Advice for bilateral tubal ligation after delivery since she's already at the age that is not suitable for safe pregnancy, and to educate the patients regarding the procedure.
Now, let us move on to our nursing care plan. So what are the nursing diagnoses that we can formulate for the client? Our group has formulated 3 nursing diagnoses for the client, which are for the mother and also for the fetus. For the mother, we have risk for decreased cardiac output related to increased systemic vascular resistance, and also knowledge deficit related to unfamiliarity with the information resources on the hypertension disease process, diet modification, precautions on advanced maternal age pregnancy, high-risk pregnancy, importance of monitoring maternal and fetal well-being, and also importance of family planning or pap smear test. For the fetus, we have risk for ineffective tissue perfusion related to altered placental blood flow to the fetus due to increased resistance of maternal blood vessels as manifested by diminished fetal movement, reduced fetal kick counts, and changes in fetal heart rate. Our group will only emphasize on 2 nursing diagnoses, which is for the mother, risk for decreased cardiac output related to increased systemic vascular resistance, and for the fetus, risk for ineffective tissue perfusion. So let's move on to our nursing assessment. Nursing assessment for our group, we have done it on 22nd of September 2020 at 9 a.m., where the client went to our clinic at KKIA SERIAN. The subjective data is that no active complaint of shortness of breath, chest pain, blurred vision, dizziness, headache, and epigastric pain as verbalized by the patient. Objective data is that the blood pressure is 139/83 mm Mercury, pulse rate of 80 beats per minute, respiratory 22 per minute, no signs of edema in both upper limbs and lower limbs. Urine test was negative for albumin and also negative for sugar, and the weight of the client is 63.4 kg. The nursing diagnosis which I have mentioned before is risk for decreased cardiac output related to increased systemic vascular resistance. So our group have formulated a nursing goals for this client, which are: patient's blood pressure will be maintained between the range of 120 to 140 mm Mercury for systolic and 80 to 90 mm Mercury for diastolic pressure throughout the pregnancy. The client will be able to recognize and report immediately for the presence of signs of hypertension such as dizziness, headache, blurred vision, edema, and epigastric pain. The client's urine test will continuously show negative for albumin and sugar result, and there will be no diminished fetal movement or abnormal fetal heart rate, where the normal fetal heart rate should be 110 to 160 beats per minute during each antenatal visit to the clinic. Next, we move on to nursing interventions. So what we have formulated is that first, educate the client on recognizing the hypertension, including the signs and symptoms, the consequences, and the efforts to prevent it from deterioration. We also need to emphasize on biweekly blood pressure monitoring, and to go to the clinic or hospital step if show any symptoms of hypertension or elevated blood pressure above 140/90 mm Mercury, and to continually monitoring the fetal kick count and fetal movement. Advise her to diet modification, especially to have low salt diet for each of her meals, and also to advise her to take medications of aspirin and calcium carbonate prescribed as prophylaxis for preeclampsia, which is the complication for hypertension during pregnancy. So our nursing evaluation is that the client's blood pressure is maintained between the range of 120 to 140 mm Mercury for systolic and 80 to 90 mm Mercury for diastolic pressure throughout the pregnancy. She is able to recognize and report immediately for the presence of signs of hypertension such as dizziness, headache, blurred vision, edema, and epigastric pain, and negative result for urine test albumin and sugar. And there is no diminished fetal movement or abnormal fetal heart rate during each antenatal visit to the clinic. Next is the nursing care plan for the fetus. So nursing assessment was done on the same day, and that the subjective data was that active movement felt and well monitored fetal kick chart by the mother. The objective data was that maternal blood pressure was 130 to 140 for systolic and 80 to 90 mm Mercury for diastolic, and the fetal heart rate was 140 beats per minute. For the nursing diagnosis, like mentioned earlier, was risk for ineffective tissue perfusion related to altered blood flow to fetus due to increased resistance of maternal blood vessels as manifested by diminished fetal movements, reduced fetal kick counts, less than 10 counts in 12 hours period, and change in fetal heart rate. For the nursing goal we did was the fetal movement will be active, the fetal kick count is achieved and completed by the mother, and the fetal heart rate is maintained at the normal range of 110 to 160 beats per minute throughout the pregnancy. The nursing interventions are monitored maternal vital signs, blood pressure, assess urine output, and signs and symptoms of hypertension during each antenatal visit to the clinic. We also need to monitor the fetal heart rate using cardiotocography (CTG) and to inform STAT if there is any abnormal reading for each antenatal visit. We need to emphasize on the mother to continue monitor fetal kick chart and fetal movement until delivery. We also advise the mother to lie in the left side maternal position as it improves fetal placenta blood flow, as mentioned by Maternal Comfort Solutions in 2020. So the nursing evaluation is that the fetal movement is active, the fetal kick count is achieved and completed by the mother, and the fetal heart rate is maintained at normal range of 110 to 160 beats per minute throughout the pregnancy. Let's move on to evaluation of overall. The client's blood pressure is maintained between 130 to 140 for systolic and 80 to 90 mm mercury for diastolic. Client showed no active sign of hypertension such as dizziness, headache, blood vision, edema, epigastric pain, or positive albumin results in urine. Head-to-toe examination was done and generally satisfactory, whereas the fetal movement and fetal kick counts are also well monitored. She demonstrated understanding in health education of various topics given by the nurses on monitoring blood pressure, fetal well-being, diet modification, risk of hypertension on fetus, preventing edema, risk for advanced maternal pregnancy, and family planning. She also currently complies with the medications prescribed. So in conclusion, high blood pressure during pregnancy can cause serious conditions that may endanger life of mother and fetus. It is important to strictly monitor maternal and fetal well-being and to go to the hospital or clinic STAT if feeling unwell. The mother who have hypertension and pregnancy also need to know about the importance of antenatal visit and health education regarding hypertension to prevent further complications of this disease. That is all for our group. Thank you.